Good morning. I would like to introduce this section with ECPR and concern to ECMO, hypothermic cardiac arrest, and all things about it. I would like to start.
Yeah. Okay, so my pleasure to introduce Burša, who is a leading physician of the Ostrava system, and they are very moving forward with their system. They are trying to catching up, so show us how you catched up. Right?
I would like to shortly introduce our program in Ostrava, which is a complex center for adult. I am glad that we have about 90 ECLS per runs per year, not only during the COVID-19 or some influenza, but I hope that it's normal situation. We start ECPR program in 222 with cannulation in emergency, so in hospital cannulation of out-hospital cardiac arrest. Because the position of the emergency is good for this, it's near to CT, near to ambulance, and we have cut lab 500 meters. It's a long trip to cannulate there. And we cover about 1 million and 2 people in the whole region. You see the numbers in the right side. So we have about 25 OHCA per year and some intra-hospital cardiac arrest. So the overall numbers you see in a right. When you see the latest guidelines, resuscitation guidelines, you see some numbers, and survivor after OHCA in the global system is about not to 10%, 7.5, and with survivor with CPC 1 or 2, about 10%. We start with first protocol in 222, which is not new things, witnessed collapse, presumed cardiac arrest, up to 70 years. And the system was set up to consider ECMO and call to ECMO team up to 10 minutes of ALS after 3 defibrillations. So it's nothing new. So we have about 230 consulted patients through 3 years, and as you see in the left side, survival to hospital discharge was in 27 patients. In the right side, in the figure in the right side, you see the time frames. So the blue lines is pre-hospital times, and red lines is cannula or hospital management. Transfer to from ambulance to emergency bed, making some echo and the cannulation, and you see that only a few patients are under 60 minutes. So the huge amount of these patients are more than 60 minutes, and the blue points are CPC score in each patient. This is some basic data from our group. So you see the outcomes of our group. Survival to ICU discharge 39%, and you see also the cause of death. So the main is brain edema, hypoxic brain edema. The more important outcomes are neurologic outcomes. So the patients in CPC 1 or 2 in all group was 29%. And when you consider the patients which are faster than 60 minutes on ECMO, there was 44%, and younger than 50, it's about 37%, but it's about low numbers, yeah. You see that the patients up to 60 minutes are only 9. If we divide it according to initial rhythm, in the VF group we have CPC score about 35%. In the first protocol we don't contraindicate the patients with asystole, but you see You see in the right that only one patient from this group had CPC 1 or 2, so it's very, very poor outcome. The main problem of our system is the time. Collapse to emergency is 55 minutes, and the management in an emergency is about 19 minutes, so about 75 minutes from collapse to ECMO. We also evaluate the long-term quality of life in this group. There is some bias, selection bias, because only 52% won't participate to fill these forms. But from this data from these patients, you see in the charts and figures. So according to SF36, quite normal physician and mental component. Also 5Q, 5D, 5L, the VAS score was 76. It's, I think, quite good. And quali 0.9, so we are happy with this. And also the anxiety and depression, according to HAD score, was quite positive. So what next? How to tune the system to faster the system and improve the quality of survival? We expected. In the beginning, we expected that the patients which are resuscitated on scene and transferred to emergency will be in the emergency about 40 minutes. But the reality is totally different, and we are about 60 minutes. So it's the main problem is the 75 minute of interval from collapse to ECMO. Basic fundamental principle of management and tune the system is this. In the beginning, get to the patient the highest possible chance to ROSC, because ROSC is the best for patients. But after maybe 30 minutes, the chance for survival with CPC 1 or 2 very rapidly decreased. So in this time frame, you have to tune the system to get the patients the ECMO as fast as possible. Logical step is move on scene, but we have to know if it's feasible in Ostrava, it's feasible in our region, consider routes, traffics, EMS system, and so all things. We make some simulations in a different part in the Ostrava, some really on scene in a forest, some in buildings, and so on. And we have the time intervals from call to ECMO about 30 minutes and faster. Yes, the cannulation of the mannequin is totally different. But according to this, we try to really move on scene and really make a new system. Our system started in last October, and in last year we have many works with simulation, training, and to learn how to tune the system, because when you perform ECPR for OHCAP patients in hospital, you have, it's not easy, yeah, but you have quite small team of nurses, physicians, cannulation team, and so on. And move on scene is much more complicated to incorporate all the people in this system, and you work with many physicians in EMS system, many dispatchers, and so on. So we start in October, but in the first 2 months we have 0 calls, so it was demanding. And in this system, the key position had the dispatcher. This dispatcher make the primary indication according to some initial information. nothing new, presumed cardiac arrest, witness, bystander CPR, and when they have information that this case should be for ECMO, they dispatch nearest EMS and simultaneously call to our team, and the team from University Hospital prepare the staff, and they are prepared to go out. It takes about 5-7 minutes, and also when the on-scene point of on-scene resuscitation is far away, we could use hams, but there is not too much patients which are managed by the hams teams. When you go to on scene, we are waiting for initial rhythm. So asystolia is a contraindication, and the teams go back. And when we have VF or pulseless electrical activity, we indicate the ECPR, and the team go to the on-scene point. So to date we have about 55 consultations. Many patients are contraindicated due to asphyxia, asystolia, age, and so on. So we have more than 20 activations of the team, and about 12 dispatch of ECPR team. We have 3 cannulations, and from these patients, 1 patient is CPC1 and very good conditions. To death, 1 patient from this is not witness collapse, but we don't know this information in the point of cannulation. You see in the left side you see the intervals from collapse to on-scene arrival, 23 minutes, cannulation and the management on scene 16 minutes, and from collapse to ECMO 39 minutes. But we are in the beginning, and this is very low numbers, only 3 patients. So we are planning to continue with this system and evaluate the effectiveness after 1-2 years. Now we are able to on-scene ECPR only on weekdays from 7 to 2:30. So maybe in the future we extend the system to 24/7, but we have some limitations of personnel, ambulance drivers, and so on. So it's about the future, and also we are planning to do a lot of training, simulation, and concern to excellent CPR, because this is the basic principle. When you do not have excellent CPR, the ECMO is for nothing. So thank you very much for attention, and we wish many CPC1 patients.
Okay, thank you. I think we should postpone the discussion after my talk just to discuss this topic. So thank you very much,
yeah.
And I will take over.
So now.
So. So it's my pleasure to talk about ECPR in Prague, and thank you very much for inviting me here. So as you know, our program has been established 13 years ago, and it's been the routine since 2012 for ECPR, and we are doing about 40 to 50 patients per year. So why we do that? because there is nothing that works in patients with refractory cardiac arrest except for ECPR and maybe alternative defibrillation strategies, which is just based on one single randomized controlled trial. And this is still not been adopted into the guidelines. So we have only ECPR, and we do have some evidence for ECPR to work. And we also do it because if we don't use any other measures to take care for patients with refractory cardiac arrest, they all, or basically most of them, die of refractoriness of cardiac arrest. So they cannot get back to return of spontaneous circulation. So you all know how it looks like. This is a typical patient out of hospital cardiac arrest coming to hospital being cannulated for refractory cardiac arrest. This particular young male, which is very usual scenario, had many unsuccessful defibrillations, and he came to hospital after 35 minutes, was simply cannulated under ongoing CPR, and this particular patient survived this refractory cardiac arrest. It took 44 minutes to ECMO. To take care for ECPR patients is very demanding to everybody. Of course, for patient, for the relatives, and for the nursing staff, and for the physician. So it's perfectly clear that we need a whole system of care for those patients, not only pre-hospital, initial hospital, ICU care, but also the outpatient clinic for those who survive because they have a lot of problems. So if you want to talk about ECPR, you have to talk about ECPR system of care in the city, in the hospital, at the ICU, and at the outpatient clinic. That's important. So what are the data? We know that there's been a randomized trial, arrest trial, which has shown that if you take a patient under ongoing CPR to hospital and you don't offer ECPR, which is the single surviving patient with a poor neurological outcome, they almost all die. If you offer ECPR, you get a reasonable chance to survive in about 43% in this very small study, having only 30 patients. We published this trial a couple of years ago, and this trial was completely different from the arrest trial. First, we had 10 times more patients than in Minneapolis. The second, the trial asked different questions. The trial asked, what do we do if we have a refractory patient on the scene and the patient doesn't have a ROSC and fulfills criteria for refractoriness? If we put a patient into the ambulance, take to the hospital, and eventually use ECPR, or we stay on site and continue until patient has a ROSC or until the patient is pronounced dead. So this has been a randomized trial. The trial has had a lot of problems, pretty difficult to interpret, was very complex, and I don't want to go into the details in this talk, just to show that there is about 8% patients from all patients with cardiac arrest who are suitable for ECPR. So that's a minority of patients, but it's an important minority. So they're young patients, they're usually very healthy, and they have a sudden collapse with sudden cardiac arrest, and they are actually good candidates for prolonged ICU care. So this is definitely the population that should be cared about. And looking at the baseline characteristics, it's also important that the system plays the role. So you see in the study we had almost 100% bystander CPR. So we selected the patients, intentionally selected the pro-trade patients who might benefit from ECPR. 80% of our candidates in the study had a telephone-assisted CPR. And you also see that it took about 25 minutes to decide for the randomization in a routine practice for transferring the patient to the hospital. So how the system in Prague works, this is our original setting, how it works. So in Prague, there's 4 centers at the moment providing ECPR. Our hospital is in a city center right over here. This is the Motel Hospital now. This is one hospital at the moment. And there is one more hospital, the ECMO hospital, which also provides ECPR. So 4 centers. During the time, those 10 years actually evolved that now we have 2 high-volume ECPR centers, our hospital, Model Hospital, covering majority of the Prague, and 2 backup centers if those centers are not available. And you see the area of Prague, which is nicely covered and divided by this row and maybe by the river. So the right side of the Prague usually covered by our hospital, the left side of the Prague and the surrounding of the Prague covered by the other hospital. And there's been several discussions and meetings with the representatives of all the institutions just to cooperate on this quite nicely. So how the works system usually right now, so there is a witness, out of hospital cardiac arrest, EMS comes to the scene, dispatch is being alerted, and we do use a fast mobile app to alert the system, and in case the patient fulfills criteria, is being transported to hospital, undergoes comprehensive CPR care, multidisciplinary follow-up care, and eventually goes back to life. This is the app we use for initial alert. So you see the crew on site sends the alert, we got an alert, we respond, and then the system is being activated. We use a cath lab cannulation for those out-of-hospital cardiac arrest in majority of the cases, so the team is ready, and you know that the coordination of the team has to be very precise. There's no space for improvisation. Everybody has to be trained to provide the best care. So if you look at the results, so I'm a little bit skipped the JAMA publication, which is complicated, but this is the publication we published on the same data, and this is as-treated analysis showing how actually ECPR works and how ECPR may change the practice. So taking the same randomized data, but regardless of initial randomization, you can see that those patients who achieved ROSC in the study, they survived perfectly well in a perfectly functioning system, so 60% neurologically favorable survival for those who achieved ROSC during the initial CPR. However, those who never reached ROSC and were offered ECPR are those red patients over here, and this is 25 more person on top of those survivors over here. In contrary, those patients who never received an option of ECPR in a randomized fashion, they have basically no chance for survival. There was only one patient who ultimately survived. So this is important analysis showing that ECPR works on top of the best care provided by initial resuscitation, getting to return of spontaneous circulation. And if you look to the subgroup analysis of the study we published, you see that in the shockable rhythm subgroup, treated invasively, including ECPR, there's been almost 50% survival for those who present with shockable rhythm, VF, VT, and are offered with system and ECPR included. So then we took the data together, and we put the ARREST trial and the Prague trial together and published this paper with the Minneapolis group, showing that if you put those patients together and you analyze just the shockable rhythms over here, you have 19% absolute benefit in patients treated invasively versus patients treated with conventional CPR, converting to number needed to treat 5, which is extremely strong intervention, as you may know. Nobody doubts about primary PCI in STEMI. Primary PCI in STEMI must be done, but the number needed to treat for PCI in STEMI is 9. So this intervention is much stronger than the PCI in STEMI if performed in a well-established system of care, including all those parts I've mentioned before. And you can look to our long-term data. We published about a year ago. This is our registry looking at the initial rhythms and the outcome of initial rhythms of all the patients who have been offered ECPR in the past about 80 years. It's 210 patients received ECPR, 196 patients were included because there were some patients who had a ROSC and then re-arrested, so we excluded those patients. And you see, based on the initial rhythm, so if you present with initial VF, you remain in VF on admission, then your chance for CPC 1 and 2 survival is 43% in the system we provide. So 43% of our patients who presented and remained in VF survived well with a good neurological outcome. And the survival goes down, of course, with the change of the rhythm. So if you convert to PEA, your chance to survive is just 20%. If you convert to asystole, 12%. And if you look at the initial PEA, still some chance to survive. 13% of those patients survived, but it's low numbers, but those numbers go down to 13 to 12% if they convert to VF or you remain in PA, and a very poor outcome of those who present with asystole. So therefore, as well as in Ostrava, we don't offer ECPR to patients with asystole. And looking at the time that we have. So this is a dynamic probability based on the data we published previously, looking at what is the chance to survive if you are like, let's say, 40 minutes of unsuccessful CPR, and then you go for ECPR. So at the moment, so dynamic probability would be about 27% to survive, and you see some kind of a plateau over here between 35 and 50 minutes. Compared to conventional CPR, if you are after 35 minutes of unsuccessful conventional CPR and you remain with conventional CPR, your chance to survive goes far below 5%. So this is a way how to show what is the timeline and how should we target the timeline. And of course, after those 50 minutes, per definition, the chance for survival goes definitely down. So the holy grail is 35 to 50 minutes of offering patients the ECPR. So looking at the data here, so this is the 3 timelines we did. So the first one is a timeline we published 13 years ago when we published the design paper for our randomized trial. So we were hoping that we get a patient on ECMO after 60 minutes right over here. This timeline is the real data from the study after 7 years of the study. So patients who have been offered ECPR actually have been receiving ECPR after 61 minutes, the same times as presented previously, that this was the aim. So we reached the aim of 61 minutes to get on ECMO. But still, looking at those results, how could we improve? So similarly, we decided to consider the pre-hospital cannulation. And this is again the proposition. So being dispatched after 15 minutes, transporting on scene for 15 minutes, and hopefully cannulate patients within 15 minutes might gain 15 minutes saved by the pre-hospital approach. So transferring to this actual dynamic probability, what we expect from this is that we convert in-hospital chance to survive of 15% after those 60 minutes back to 35% when using out-of-hospital cannulation for ECPR. So this is the theory, therefore we established the team. The team actually and the pre-hospital was established 2023 when we started to prepare and simulate it for, and been consulting with the EMS system, and we simulated during the 2024 many cases around the Prague, the similar way as they did this year in Ostrava. And you see this is one of the first cannulations on the streets of Prague. Another one, I'll show you how it works. And this has been on the Wenceslav Square, so necessary selfie on the Wenceslav Square. So just that you have an idea how this works, this is the real life scenario from the Wenceslav Square. So it was a young male, 40 years old, Ukrainian Marine, actually, who came to Prague and arrested on the scene. There's been some problem with the initial alert of this patient because it was on the Wenceslav Square and this is very close to our hospital. So we said, okay, transfer the patient to the hospital. They said, no, this is a bad place, come to here. And then the phone crashed, so we had to call again. There's been 10 minutes actually delayed to deciding what we're gonna do. So you see, but at the end we came to the scene after about 32 minutes of resuscitation. At the time the patient was still in ventricular fibrillation, still fibrillated 8 or 9 defibrillations already. And you see the cannulation, how it works. So it's pretty easy for the EMS crew, not so easy for us. So this is the vein cannulation, and we always put in the sheets to be sure that we are in the proper vessel. So this is the sheet secured on the scene, and then so this is the sheet being inserted. In the meantime, the colleague changes and the perfusionist prepares the circuit, and this is completely reliable. There is no shortening of the videos. We will see the whole case, which is not so long. So this is one sheet secured, and then we go to the other one again. And you see you are playing on the outside playground, so you don't have any fancy devices, no X-ray. We have, of course, ultrasound, but I'm old-fashioned. I've been doing this for 20 years, so I use ultrasound only if it doesn't go with the first touch. But we still use it for the second groin or if we are not able. So this has been the vein, and now we are in the artery, well cannulated. So in the meantime, there's a stiff wire prepared by my colleague for the cannulation sheets. And based on experience, based on how you feel in your fingers, you can recognize nicely whether you are in the vein or in the artery. So not in all patients, but in majority of the patients. So now the groin's been cannulated, and you see this is the stiff wire for putting in. The main problem in out-of-hospital cannulation or any cannulation which is outside of the cath lab is to be sure that your wire in the vein goes up and doesn't stick, it's not somewhere in the renal vein or whatever it might be. So this is the main problem, so you have to be sure that the wire goes through the inferior vena cava up to the right atrium, which is not easy on the scene. So the only way you can attend is either by ultrasound or by your feeling of the fingers, and that's all you can do. So if we are not sure, we use, of course, ultrasound to be sure that the wire is properly in the vein. So you see 25 French venous cannula being put into the body right here. Now, you see still ongoing CPR and defibrillations in the meantime, and then the easy insertion of the cannula right over here. And then you always wait for the backflow to be sure that you are well in the vein. Oh, sorry. Můžete tam dát to video někde do poloviny? Sorry, jsem se tam překliknul. Asi v polovině to klikněte. No, třeba. Puste to. No, ještě dál, kousíček dál, ještě dál, ještě dál. No, okay, down. Okay, so now we have a vein cannulated. We insert the arterial cannula right over here, and again the nice backflow. So the backflow is an important part. So to be sure that you are well in the vessels, and then just to attach the extracorporeal circuit, and hopefully we are done. Můžete to posunout možná? Trošku to posunout. Tak. At the moment now we are cannulated. If you look at the time, this is 5 minutes 40 seconds from the time we came to the scene to the time that the ECMO was flowing. So this was one of the fastest cannulation. We still work in the working hours, 3 members of the team, 2 physicians, 1 perfusionist. This is the particular patient that was cannulated. It was a very, very complicated hospitalization. He had a lot of problems, has rearrested, had another ECMO, several PCIs, but he left hospital very well. So and now I apologize, I'm in Czech, but this is the summary of the system. So what is that? This is a pilot observational study of our center and Prague EMS. We use selected patients with out-of-hospital, but also with in-hospital cardiac arrest in different hospitals in Prague. We have already cannulated 3 patients in different hospitals in Prague with refractory VF or PA. Why? Because we expect this to be faster and to hope to get more survivors. We were preparing those 2 years, started January 2025 during the working hours. And since that time, we had 12 patients cannulated on the scene by the mobile team. The median age was 56 years. 10 of 12 patients were male. We succeeded cannulations in 11 of 12 patients. All the cannulations were below 10 minutes of time on the scene. And you see the median time very nicely, as in Ostrava, was 39 minutes, but out of those 11 cannulated patients, which is far shorter than the original time in the ECPR. So at 30 days, we had 42% alive, 25% with good neurological outcome. And importantly, this population is as a byproduct, very beneficial for the society and for the medicine. 4 of those patients became organ donors, and you might see we have published some of those cases. So today we have a hybrid system in Prague, combining pre and in-hospital system depending on the time and of course depending on the patient. And to finalize, ECPR has been awarded a 2A recommendation by recent American guidelines. The European ERC guidelines on ECPR are underway. They should be published this year. I'm in the steering committee together with others, so hopefully we will have a new guidelines. And 2A recommendation is a strong recommendation. This should be considered in refractory cardiac arrest. Still, we do need some more data in the hospital cardiac arrest, and let me know that if you come to our ECPR meeting, you will get everything concerning ECPR. Thank you for your attention.
So thank you very much. I would like to ask, what is the was this the one or two things when I have to tune in the next on ECPR? Because there is many things to solve the problems, but what is your next problem which you have to improve, solve, or?
We have no problems. No, this is very complicated. And as I said, this is the system of the care. Yeah.
And you are 24/7? Or?
We are 24/7 for ECPR, for the hybrid system. We are 24/7, but not for pre-hospital ECPR. Yeah. We are working on that, but you know, you need a specialized team, you need enough crazy people doing this, so it's not everybody. And more or less, those people, they cannot wait for the alert, they are working, they have other duties, of course. So it's really logistically complicated, but, in comparison to your system, we are not dispatching to every cardiac arrest. This is insufficient. This is wasting of the time of the expert. So we are dispatched only if we have confirmed ventricular fibrillation as the initial rhythm, and then if we confirm the refractoriness, so at least 3 defibrillations failed. So that's the difference to the other systems around Europe. So we don't want to waste the time of the system, but we want to go fast to those patients who really need it. So the initial alert, initial communication is the major problem. And paradoxically and interestingly, if we have a patient who arrests and there is a call to the EMS and the system is started, it works perfectly well. The most problems we have with those patients who, when the EMS crew comes to the scene, the patient is awake, stable or marginally stable, and then gets cardiac arrest, then to switch the meaning and mindset of the crew on the scene is problematic. So before they start the ECPR track in those patients, it takes much longer time than if the patient arrests and the system is started immediately. So that's the problem.
Yeah.
I have another question. So first, thank you both for the excellent talk. Very interesting and impressive, your initiatives on ECPR out of hospital. My question is, are all those patients primary cardiac arrested? Or among those patients also hypothermic cardiac arrests? And do you use the same management method and strategies for both? Or do you differ between hypothermic and normothermic cardiac arrests?
The patients I've been showing are not hypothermic patients. We offer ECPR to all hypothermic patients if they are patients suitable for complex ICU care. We share this with our general ICU, and those patients are usually 5 to 7 patients per year in Prague, cannulated for refractory cardiac arrest due to hypothermic cardiac arrest. And as you're going to talk later, we don't consider this to be to discuss. So all the patients suitable for ICU care are offered ECPR in Prague.
And another question, Philip, here in Ostrava, do you have mechanical chest compression devices available also out of hospital in the ambulances?
Yeah, sure. The system is the same as in other cities. We have Lucas for this. So if we transport the patients to the hospital, is under the Lucas. And the numbers in my presentation, there was only the patients with ongoing CPR with Lucas. So when the patients had ROSC, I don't show in the tables. So it's patients in cardiac shock, cardiogenic shock. And we don't have, in Ostrava, we don't have many people in the hypothermic cardiac arrest, and we have only a few patients per year with cannulation of VA due to hypothermia. This season, only one patient which was consciousness, and he was 85 years old, and he was CPC1 for the war time. So we do this, but only a few patients per year, not so much. And hypothermic very rarely, only few patients per 10 years, maybe 5, maybe.
We already had a patient who had 2 hypothermic cardiac arrests with ECPR surviving, so some of those patients come back. They usually live on the streets, and it's kind of the population in Prague we cannulate for hypothermic cardiac arrest.
So is there any questions, Hansa?
Good morning, and thank you for your excellent speech. I have one question. I hope I didn't miss the information, but what is the perimeter for your pre-hospital ECPR, and how do you cope with the usual traffic jam in Prague?
A good question. That's why we simulated for long. That's why we train during those hours. And the perimeter at the moment is just Prague, so and the closest area. And in the majority of those cases, we get within 20 minutes from alert. So that's still time which can be spared. We also simulated with the mid-Bohemian area, and we simulated like and it's still we got in 20-22 minutes, so there still might be a time gain by this, but we have not moved to mid-Bohemian region. This is the plan in upcoming months, and I think there is still, because we don't offer in-hospital ECPR for patients outside of the Prague, because historically we have a strong experience that by doing this we get to long times, and basically nobody is going to survive. So we don't offer patients in-hospital ECPR for out-of-hospital cardiac arrest to be transferred from the outside of the Prague at the moment, except for HEMS, but it's a different story.
We make some map in Ostrava based on the times of ground transport to on scene. I have this in a presentation, and for now we have 30 minutes of perimeter, but it's not a circle. It's according to real time on ground transport, according to roads, main roads, and so on. So we have in the beginning the big perimeter for this.
It's important to consider that we have, started this based on very detailed evaluation of our previous results, and the problem in the time delay is not the transport itself. The problem is extrication of the patient from the scene to the car. So if you have a cardiac arrest at a public place, that's easy. But having cardiac arrest at home, that's the problem. So in those patients, we feel that we might have the most benefit, because the time from saying yes, go from the home to the car takes 10-12 minutes sometimes, and that's the major part of the transport, not the transport itself, meaning from the ambulance car to hospital.
And I think that one positive things of on scene is that you don't have managed transport with Lucas, because last year we have many patients with terrible hemorrhagic shock due to transport with Lucas. When you are in a 5th floor in the building, the transport the patients with Lucas on some scubram or so on is very difficult. So I hope that on-scene ECPR will be with not so much liver hemorrhage or thorax hemorrhage and so on.
But as you know, there's an ongoing trial, on-scene trial in the Holland, going with the HEMS system. But this is not a randomized trial, and this trial might be a nice trial to show feasibility of doing this using HEMS around the Netherlands. But this trial will not answer the question whether it's better or not, because it's a very, very selected population, as you know.
Thank you so much for your excellent speeches and your tremendous efforts to put these all things into life. As you mentioned, HEMS in Netherlands, I would just add that they are never transporting patients on helicopter. So Denise Miranda put ECMO on all helicopters actually currently, but they even do not have vacuum matrice on the stretcher, and they have full helicopter of all ECMO devices, and they just have the system transporting the physician's team to the patient, but never use helicopter for transporting patients. So I think it's not possible in our country because our HEMS is responding to majority of traumatic patients, and we need to get a patient as soon as possible to the trauma center. So it's a little bit different system.
It's different, completely different. I agree, and I have had many discussions with Dennis, and we had a debate, and I actually don't think that his system is well, functioning, and it's a very ineffective system. His rate of false alerts is about 90%, so it's completely non-cost effective. So we don't go this way.
What is your opinion? How many centers should be initiated in Czech Republic? ECPR centers.
It's not about how many centers should. It's about how many patients need it. And how many patients need it? It's very easy. So we have prepared some kind of international collaboration on this. So I'm completely convinced that areas and cities with 500,000 patients at least should consider to have a system for ECPR, because then you have a chance to have about 30 to 50 refractory cardiac arrest cases per year statistically, and this is what should be done. So at least 1 or 2 cases per month.
Thank you.
Is there any questions from the audience? So if not, we move to next lecture, and I would like to say welcome to Dr. Czober from Katowice with hypothermia and management of patients with deep hypothermia. Thank you.
Ladies and gentlemen, good morning, and once again I'm Tomasz Czober, and I'm an anesthesiologist working under the supervision of Professor Tomasz Darocha at the Department of Anesthesiology and Intensive Care of the Medical University of Silesia in Katowice, Poland. Firstly, I would like to express my gratitude for the invitation to this forum, and the present discussion will focus on 2 clinical situations. Patients with hypothermic cardiac arrest and severe circulatory instability with preserved circulation. And these 2 distinct clinical situations demand a departure from the conventional normothermic management of ECMO and ECPR, and the departure constitutes the primary focus of today's presentation. I don't know what's happening. Sorry, I declare non-conflicts of interest. Accidental hypothermia is a condition in which the core body temperature unintentionally drops. What's going on? I don't touch anything. So, once again. It doesn't work. Yeah, okay. Sorry for that. Yeah, something clearly doesn't work here for me. Okay. Although it's often associated exclusively with exposure to cold, it actually affects very different groups of patients, both young people after injuries or accidents in the field, and elderly patients with comorbidities often found in domestic setting. The simplest and most intuitive way to describe hypothermia is by temperature, of course. And there is a mild hypothermia in the range of 35 to 32 degrees Celsius, moderate hypothermia between 32 and 28, and severe hypothermia below 28 degrees Celsius. And this classification is widely used and useful as a reference point, but it has significant limitations. At the same time, there are clinical classification systems which are based primarily on the clinical picture, level of consciousness, present or absence of circulation, rather than temperature alone. Etiological approaches are also used, distinguishing between outdoor hypothermia associated with environmental exposure and indoor hypothermia typical for elderly patients with comorbidities. Classifications based on physiology and risk assessment, which take into account hemodynamic instability, the risk of sudden cardiac arrest, and survival prediction models are also becoming increasingly important. And the common conclusion of all modern guidelines is that core temperature alone or any other single clinical parameter is not sufficient to assess the severity of a patient's condition or to make therapeutic decisions. Hence, the evolution of the clinical approach towards multifactorial probabilistic scales. I don't know, because... What?
You have some animation?
No, I don't have any animations. So... Slide 4. Once back. Back.
6 or 7?
This. The reason why we consider aggressive treatment primarily in cases of cardiac arrest and hypothermia is the existence of a biologically plausible mechanism of organ protection, which is particularly important in the context of the central nervous system. This creates a window of tolerance for ischemia by organs, which is extremely limited in analogous clinical situation in normothermia. Clinically, this translates into observed survival with good neurological outcomes in selected patients with hypothermia, as confirmed by registry data. And in the SAFE-G2 study, survival to hospital discharge in cases of HCA was 45%, almost twice as high as in ECPR performed for other reasons. A favorable neurological outcome, CPC 1 or 2, occurred in 27.5% of all patients treated extracorporeally with ECLS. Which is more than twice the percentage of ECPR for cardiac arrest due to other reasons. Can you move it next? Yes, 5. I'm sorry, I don't know what's happening because it was working earlier. So. 5. In hypothermia, both assessment and treatment begin in the pre-hospital setting. Direct contact between the emergency team and the experience center, efficient coordination of activities, rapid diagnosis, proper handling of the patients, avoidance of rescue collapse, protection against further temperature drop, efficient transport to the appropriate hospital, and maintenance of the effective CPR if cardiac arrest occurs. And these are the elements that directly translate into the outcome. So in the chain of survival graph, as you see, the size of each element corresponds to its importance. As we can see, the pre-hospital phase often plays a key role in the survival of the victim. Next slide, please. Common mistake made during qualification is the automatic application of normothermic criteria for ECPR qualification disqualification. In hypothermia, these indicators do not have the same prognostic value because the physiology and pathophysiology of the body in response to a drop in core temperature significantly changes the patient's prognosis for survival and survival with a good neurological outcome. Decrease in temperature leads to a decrease in metabolic rate, oxygen consumption, and free radical production, and inhibits the inflammatory cascade apoptosis. It is estimated that oxygen consumption by the brain decreases by approximately 6–7% per 1 degree Celsius drop in core temperature. So neuroprotection associated with lowering body temperature has been clinically confirmed, among others, in cardiac surgery. Other organs also reduce oxygen consumption as the temperature drops, although not to the same extent as the central nervous system. Next one, please. Previous. The latest ALSO 2025 document emphasizes narratively hypothermia is a special situation and requires selection based on phenotype and predictive models. It gives clinicians a framework and emphasizes the importance of developing the tools that can be used at the scene and bedside for qualification. And in recent years, there has been a significant change in the way patients suffering from deep hypothermia are qualified or disqualified for mechanical circulatory support therapy, primarily related to a paradigm shift from single parameter, namely usually potassium blood levels assessment, to assessment during a series of models that take into account a larger number of variables, which I will try to discuss in the following part of my presentation. So we start the block with qualification in hypothermic cardiac arrest and scales. Next slide, please, and one next. Let me start with the problem. For years, eligibility for ECLS in hypothermic cardiac arrest has been based typically on a single parameter, mainly potassium threshold values. This is a simple approach, but clinically in some sort of situations may be risky, as potassium measurement can be prone to error, and there are many possible clinical causes of hyperkalemia other than cardiac arrest. Relying on any single clinical exclusion parameter may lead to failure to initiate treatment that is potentially life-saving for some patients. The HOPE score was developed as a result of change in approach. Instead of a single cutoff point, a multi-factor model was proposed, which gives us the probability of survival after ACLS rewarming. This is important because in hypothermia, unlike in normothermia, survival with good neurological outcome is realistic even after prolonged resuscitation, and decision must be more phenotype aware. In the base study, HOPE has a clearly better ability to differentiate survival than single parameters alone, which is an argument for HOPE to become the triage tool. Next one, please. Here we clarify the definition. The HOPE score does not predict overall mortality in hypothermia. It is not a refusal algorithm. It answers a very specific question. What is the probability of survival to hospital discharge in a patient with hypothermic cardiac arrest if ECLS is used? It does this on the basis of 6 variables that are often available immediately upon admission: age, gender, mechanism, is asphyxia suspected, core temperature, potassium concentration, and the time from starting CPR to the start of ECLS, which is an estimated time because we assess it earlier. So this is a practically estimated low flow time until extracorporeal circulation is started. The result is a percentage, so a probability, not a 0, 1, yes, no. It supports the team in making a decision that should be based on the overall clinical picture available. Now for the hard data, the cohort on which HOPE was built its model consisted of nearly 300 patients in hypothermic cardiac arrest who were rewarmed with ECLS. Survival was approximately 37%, and crucially, most of those who survived had a good neurological outcome, CPC 1 or 2. This immediately sets the perspective for us. We are talking about a group in which aggressive treatment can have a qualitative effect. The HOPE model had very good discriminatory power. It was also externally validated in 122 patients and survival rate of approximately 32%, good calibration. In practice, the proposed cut-off threshold of 10% is associated with a very high negative predictive value, which usually means negligible chances of survival despite ECLS. However, it must be said in all fairness that there are possible rare exceptions. Therefore, HOPE is a decision support tool, and no numerical value is an absolute disqualifying criterion. ELSO 2025 gives us a kind of guide. It directly integrates HOPE with qualification. If a patient in hypothermic cardiac arrest has a core temperature equal or below 30 degrees Celsius and the predicted survival rate according to HOPE of at least 10%, then they are the candidate for ECLS. The second situation is severe hypothermia of hemodynamic instability. Here ECLS may be indicated to prevent another secondary cardiac arrest, but we will discuss this later in the lecture. And how to do this in practice? Step 1, recognize severe hypothermia and do not allow the patient to continue cooling down. And in the case of HCA, maintain high quality CPR. Step 2, activate the SLS center early and plan transport to the center. Step 3, collect the HOPE variables and as soon as possible. Step 4, if HOPE is 10 or higher, treat the patient as a candidate for ECLS. If it is below 10%, this does not necessarily mean disqualification, but therapeutic failure is very likely. And a very important logistical element also emphasizes that long transport with continuous CPR should not in itself be a reason to discontinue efforts. Another scale, which was developed relatively recently and is currently undergoing external validation, is the HELP score. And the HELP score was developed based on the retrospective analysis of data from the Polish registry of hypothermic patients, including adult patients with hypothermic cardiac arrest and a core temperature 28 degrees Celsius and below, treated with ECLS rewarming in a specialist center. This temperature threshold is lower than that used in the HOPE score and clearly defines the populations with severe hypothermia. Asphyxia-related cases, such as drowning or avalanche barriers, were excluded from the cohort in order to focus on the phenotype in which hypothermia preceded cardiac arrest rather than being a consequence of it. And in this population, survival to discharge was approximately 36%, and among survivors, 88% achieved a good neurological outcome, CPC 1 or 2. It shows that in properly selected patients with non-asphyxia-related hypothermic cardiac arrest, treatment with ECLS can lead to a high survival rate with an acceptable neurological outcome. And the HELP model is deliberately simple and is based on 4 variables that are available almost immediately upon the admission of the patient. The first is exposure, so exposure conditions, outdoor versus indoor, treated as an indirect marker of age, comorbidities, and physiological reserve. Observation of cohorts of patients with severe hypothermia clearly showed that outdoor patients are usually younger and healthier. They are the victims of avalanche burials, missing persons in the mountains, etc., while people who have fallen to hypothermia despite being indoors are usually older, very frail, and have numerous comorbidities. The second is hemoglobin, interpreted by the authors as a marker of frailty and the patient's general condition. The third and fourth variables are blood potassium and lactate concentration, which indirectly reflect the severity of metabolic disorders and cellular damage. The direction of the relationship is clinically logical. Outdoor exposure and the higher hemoglobin increase the chances of survival, while higher potassium and lactate decrease them. The model achieved good discrimination and good calibration after internal validation. At the same time, the limitation must be stated very clearly. So HELP applies only to non-asphyxia, hypothermic cardiac arrest, and was developed in a cohort of patients who had already undergone ECLS, which is associated with selection bias, and has not yet been externally validated. Therefore, clinically, we should treat HELP as a complementary tool, particularly useful in urban, non-asphyxia-related hypothermic cardiac arrest. These slides aim to show that HOPE and HELP are not competing scales, but were developed based on analysis of slightly different patient cohorts and with different prognosis and phases. HOPE was developed based on a broad population of HCA patients and also includes cases with asphyxia. In the model, temperature is not a qualifying threshold, but a continuous variable that contributes to the probabilistic assessment of survival together with CPR, time, potassium, H, and RS mechanism. For this reason, HOPE works well as a tool for organizing decision at an early stage of qualification. HELP, on the other hand, was developed in a more homogeneous cohort of non-asphyxia hypothermic cardiac arrest patients with a core temperature 28 and below, treated with ECLS. This scale deliberately does not take into account CPR time or temperature, but focuses on parameters reflecting physiological reserves and the severity of metabolic disorders, such as hemoglobin, lactate, and potassium concentration, and exposure conditions. In clinical practice, this means that HOPE may be used as the primary triage tool in HCA, while HELP allows for a more precise prognosis in selected non-asphyxia HCA phenotypes. This approach is consistent with the ELSO 2025 narrative guideline. So next block is why normothermic ECPR criteria do not really work in hypothermia. Before we begin interpreting markers and before we even compare the patient to normothermic ECPR, we must name the phenotype. In hypothermia, it is the phenotype that determines whether hypothermia could have had a protective effect or was merely a late element secondary to asphyxia or prolonged hypoxia. Therefore, the first question is, are we dealing with a mechanism of asphyxia like drowning, avalanche burial with no air pocket, prolonged airway obstruction? Patients in this group have a significantly lower probability of survival. The second question is the context, indoor versus outdoor, because indoor more often means an older patient with multiple diseases and lower physiological reserve. Only in the context of the victim's phenotype should we interpret the remaining parameters and decide on further treatment. Serum potassium concentration is a very strong marker, but its value is strongly phenotype dependent. And this is where it's the easiest to make a mistake when someone tries to make potassium an universal stop rule. For many years, serum potassium concentration has been documented as a strong predictor of survival death in patients with severe hypothermia. And high serum potassium concentrations in patients are associated with high risk of irreversible damage to the body cells, including the brain and heart. In the Avalanche cohort, so the classic scenario of asphyxia-related hypothermia with out-of-hospital circulatory arrest, Professor Brugger and co-authors showed that potassium at admission has a very high triage value. They proposed cutoffs of blood level of potassium 7 millimole per liter and core temperature 30 degrees Celsius as optimal for qualification for ECLS rewarming. But this is an important finding, but it applies only to Avalanche cohorts and should not be extrapolated to other phenotypes. In urban hypothermia and in some non-asphyxia related cases, high serum potassium level may result from chronic renal failure, rhabdomyolysis, analytical errors, or medication simply. So in such cases, potassium ceases to be a marker of irreversibility and becomes a non-specific marker. In normothermia, severe hypoglycemia is considered a high-risk factor for the brain damage, and it's sometimes the reason for reluctance to adopt an aggressive treatment strategy in the form of ECPR. In hypothermic cardiac arrest, this approach may lead to selection errors. Plute and co-authors analyzed patients with hypothermic cardiac arrest and a core temperature 28 and below, treated with ECLS rewarming. Severe hypothermia was defined as glycemia below 3 millimole per liter, and in the entire cohort, 17% of patients met this criterion. And the key finding is practical. 38% of patients with severe hypoglycemia survived to discharge in good neurological condition, which did not differ significantly from the group without severe hypoglycemia. Furthermore, the lowest blood glucose level in a patient who survived without neurological deficit was 0.9 millimole per liter. And this slide shows why end-tidal carbon dioxide concentration should also not be used as a decision criterion in hypothermic cardiac arrest. So in the analyzed cohort of patients with refractory cardiac arrest assessed for ECPR, hypothermia was associated with significantly lower ETCO2. values. At the same time, when blood gas analysis was interpreted in terms of pH stat, so corrected to the temperature, partial pressure of carbon dioxide was also significantly lower than normothermic normal range values. Whereas in terms of alpha stat, so non-corrected to temperature, this difference was not significant. Crucially, no association was found between EtCO2 and survival in the hypothermic group. An important element of this analysis is the fact that hypothermia did not cause a significant change in the gradient between pH stat partial pressure of carbon dioxide and end-tidal carbon dioxide. This means that low EtCO2 did not necessarily reflect inadequate resuscitation, but rather was a consequence of altered carbon dioxide exchange physiology. On this slide, I focus exclusively on low flow time, so the duration of resuscitation, and on the initial cardiac rhythm. In hypothermic cardiac arrest, again, prolonged low flow is very common. Resuscitation is often performed for a long time, often in difficult pre-hospital conditions. At the same time, reduced body temperature alters body tolerance to ischemia. So data from registries and ECLS cohorts show that the duration of low flow alone does not determine the futility of treatment in hypothermia. The second factor is the initial rhythm. Asystole and PEA are also common in hypothermic cardiac arrest. However, data from both the International Hypothermia Registry and ECLS analysis show that non-shockable rhythm does not preclude survival with a good neurological outcome. Unwitnessed cardiac arrest is one of the most frequently cited arguments for terminating resuscitation, but even this clinical situation does not necessarily constitute a criterion for excluding a patient in deep hypothermia for ECPR. Unwitnessed cardiac arrest primarily means an unknown or potentially long period of no flow. In normothermia, such a scenario is usually associated with a catastrophic neurological prognosis. In hypothermia, this relationship is not linear. Data show that unwitnessed hypothermic cardiac arrest does not preclude survival, including with a favorable neurological outcome. Age is a factor that has a strong impact on prognosis and should be taken into account when assessing patients with hypothermic cardiac arrest, because with age, obviously, physiological reserve decreases and the burden of comorbidities increases, which in many series of patients warned using ECLS is associated with poorer survival outcomes. And this is a recurring observation. But at the same time, the available data and also narrative guidelines clearly indicate that age alone does not define the futility of treatment in hypothermia, and the oldest case was, I think, in Norway, and it was a 95-year-old patient who survived with good neurological outcome. This is a little summary of my previous presentation, and the most important conclusion is simple. In hypothermia, there is no single parameter that in itself defines futility of treatment. The next block is assessing the hemodynamically unstable patient in hypothermia. And I would like this part of this lecture dedicated to unstable patients by drawing attention to a phenomenon called rescue collapse. Rescue collapse is a sudden circulatory collapse that can occur during evacuation, patient manipulation, or the early phase of rewarming in a patient who had maintained circulation just a moment before. The key point is that this is not a random event. Its risk increases with the severity of hypothermia and the hemodynamic instability. The mechanisms are multifactorial. A cold heart muscle is extremely arrhythmogenic. After drop and sudden changes in preload occur, and the stress associated with transport and handling can provoke malignant ventricular arrhythmias. Importantly, the risk is dynamic and not always visible in static admission parameters. From a clinical point of view, this means that a patient with severe hypothermia and hemodynamic instability may decompensate during the rescue itself, even if they were not initially in cardiac arrest. the occurrence of rescue collapse statistically doubles the risk of death. Therefore, guidelines and registry data emphasize the importance of minimizing manipulation, careful transport, and planning controlled rewarming, and in high-risk patients, early consideration of the ECLS pathway, not because it guarantees survival, but because it can reduce the risk of catastrophic rescue collapse. In severe accidental hypothermia in patients with preserved circulation, the key clinical problem in the context of possible HCA is not body temperature itself, but hemodynamic instability, which reflects the risk of cardiac arrest. And data from Podsiadło and co-authors showed that patients with a core temperature 28 and below, who initially have preserved circulation, exhibit objective parameters that may predict hypothermic cardiac arrest. And the strongest one is bradycardia with a prognostic threshold of approximately 33 beats per minute. In addition, there are ventricular arrhythmias, borderline temperature-corrected partial pressure of oxygen, and metabolic disorders expressed as negative base excess. And this picture is complemented by data from Mendrala and co-authors, which show that systolic blood pressure below 90 millimeters of mercury is associated with significantly higher mortality in patients treated without ECLS. This means that the patient with severe hypothermia and any of these parameters should be treated as unstable, even if initially conscious. The risk of deterioration in patients with severe hypothermia can be assessed both pre-hospital and in-hospital. The pre-hospital model is based on immediately available parameters like heart rate, presence of ventricular arrhythmias, and systolic blood pressure. And this combination alone allows the identification of patients at high risk of further destabilization. The hospital model additionally takes into account blood gas parameters, in particular temperature-corrected partial pressure of oxygen and base excess. From the perspective of the ELSO guidelines, hemodynamic instability in severe hypothermia is an indication to consider ECLS not only as a treatment of cardiac arrest, but also as a preventive strategy. Transporting an unstable patient to a hospital without ECLS facilities increases the risk of cardiac arrest during rewarming and the need for secondary transport with ongoing resuscitation, leading to prolonged low flow time and possibly worsened prognosis. For these reasons, patients with severe hypothermia and signs of instability should be referred primarily to SLS center. This is an important slide because data on the benefits of extracorporeal rewarming remain inconsistent and depend on the patient's phenotype mainly, the definition of instability, and the risk profile for complications. In European data presented by Podsiadło, in a population of patients eligible for ECLS in the context of hypothermic shock, defined as hypotension with SBP below 90 millimeters mercury, ventricular arrhythmias, and in some cases the presence of ROSC prior to admission, the use of ECLS was associated with significantly higher survival compared to conventional treatment, with a comparable incidence of bleeding. In contrast, an analysis of data from the ice crash study concerning patients with severe hypothermia and circulatory instability without cardiac arrest did not show a survival advantage in the ECMO strategy compared to non-ECMO management, despite the significantly higher rewarming rate in the ECMO group, but, on the other hand, showed a significantly higher incidence of bleeding requiring transfusion. It's important to say that in the Japanese cohort, it is the population was significantly older with a predominant mechanism of indoor hypothermia, which clinically can correspond largely to the phenotype of secondary hypothermia with significant contribution of comorbidities and non-hypothermic causes, which means that the impact of ECMO on survival may be masked by competing mechanisms of death. Also, in ice crash, the definition of instability was more rigid in terms of parameters and included SBP below 60 millimeters mercury, heart rate below 50 is actually quite higher, and even unmeasurable blood pressure. So from the point of view of ECMO eligibility in unstable patients with preserved circulation, it is crucial to distinguish between the phenotype of primary hypothermia and secondary hypothermia, indoor hypothermia. So the last block, few words, because many more experienced people are today with us. But ECMO conduct, based on the 2025 ELSO consensus, specifically in hypothermia. So mode and configuration, ELSO guidelines. ELSO guidelines tells us that both VA ECMO and CBP are possible, but in practice VA ECMO has logistical and not only logistical advantages, it's smaller, less hemolysis is observed and can be maintained longer, but in the situation of lack of ECMO machine we can use CBP temporarily. Cannulation, the default strategy is femoral-femoral bilateral cannulation with distal perfusion cannula, and because of high risk of bleeding, it should be performed under ultrasound guidance with through the puncture of the skin. Okay, this is an important slide also because it answers the question which is frequently asked. Firstly, ECMO or firstly CT scanning. And also is clear in its statement. In hypothermic cardiac arrest, cannulation and rewarming should not be delayed for CT scanning. If trauma is suspected, ELSO also recommends a change in typical sequence. So first stabilize the patient's circulation with VA ECMO and then perform diagnostic imaging. It is also worth noting that in patients with preserved circulation but severe hypothermia and instability, transport to CT may by itself trigger rescue collapse. Therefore, the decision to transport must be made with great caution. Anticoagulation in hypothermia, one of the most problematic issues, also clearly confirms the need of anticoagulation in ECMO, but at the same time allows periodic VA ECMO without heparin or very low doses of heparin. And please note, it should be remembered that despite severe clinical features of hemorrhagic diathesis, laboratory tests of the coagulation system may remain normal or show only slight deviations due to the fact that these parameters are assessed in a test tube heated to 37 degrees Celsius. This is related to the fact that coagulation disorders in patients with deep hypothermia result mainly from impaired functioning of coagulation factors in conditions of reduced body temperature. Rewarming rate. Few numbers to remember. Rewarming rate for up to 5 degrees Celsius per hour, and the initial gradient between venous inflow temperature and arterial outflow temperature cannot reach more than 4 degrees of Celsius. And the last thing, the difference in temperature between venous inflow and water in heat and cooler machine cannot reach more than 10 degrees Celsius. Also clearly states that we should use alpha-stat strategy of assessing arterial blood gases, as it is more neuroprotective strategy. Also, we should, it's a kind of standard procedure, so we should also in hypothermia monitor the arterial blood gases from right radial artery. We should monitor cerebral oxygenation, and in the case of progressing differential hypoxia, we should consider veno-arteriovenous, switching to veno-arteriovenous ECMO. Perfusion pressure and fluids vasopressors are not clearly stated in this document, but we need to remember that in early phase of rewarming there is a great need of fluid therapy, so we should start with massive fluid resuscitation. Ventilation and lung protection is a standard lung protective ventilation, but also we should remember that patients with hypothermia who are rewarming suffers from the pulmonary reperfusion pulmonary edema, which can be in some situations can be pretty massive and develop severe ARDS. Also states that the left ventricular distension is very uncommon and venting of left ventricle isn't necessary in most cases. This is a little summary, so thank you for your attention. Sorry for the issues at the beginning. Thank you very much.
Okay, thanks very much. We will defer the discussion after the second talk. Thank you. And it's my great pleasure and honor to welcome Dr. Brugger from Bolzano, Italy. Please.
Thank you. First of all, before I begin my lecture, I would like to congratulate Thomas on his speech because the group around Tomek Tarocha in Katowice and in Poland is one of the leading groups working on hypothermia, and they're doing a really excellent job. And they give us the basis for the treatment of hypothermia out of hospital, in hospital, and also to differ between the patient groups. And I fully agree with you that the phenotype should be considered more than previously, because phenotype asphyxia from avalanches, from drowning, is not comparable to the phenotype of exposure without any hypoxia. So the parameters responsible for the outcome are quite different, and you are going this way. I think this is the way we should go for. So I'm talking about avalanches and how much avalanches contribute to hypothermia and hypothermia treatment, as we have seen that hypothermia treatment without hypoxia has a very good outcome. Too many people die out of hospital from hypothermia because it is underdiagnosed at all. So I splitted my lecture into 3 parts. First, pathophysiology of the avalanche burial, the current guidelines for the field treatment, and I close the speech with some very instructive clinical cases which give us future directions because they are a little bit extraordinary. So the epidemiological course of avalanche fatalities in the last decades does not change. So the mortality, the number of fatalities remains almost equal from the 1970s to nowadays. And this means that all those initiatives to decrease the mortality, the lethality, was successful because the number of exposed persons increased, not only doubled, but today I think it will be 5 times higher than in the 1980s or 1970s. So the number of skiers, off-piste skiers, snowboarders, snowshoers, these numbers are considerably increasing. So this means that lethality decreased in these times. But what is important to us as emergency physicians? What are the decisive factors for avalanche survival? And you see this lady is smiling happily. And this is the main factor for survival. It's the grade of survival. If in total 21% or 22% of all persons involved in an avalanche accident die from the avalanche. This is quite depending on the completeness of burial. If the person is completely buried, we talk about critical burial. That means that the head and the chest is under the snow. Then the mortality is as high as 51%. But if you are able to keep yourself on the surface and the head and chest not supposed to be asphyxial, then the mortality is very low, so it's 4.4%. If this is not possible to keep yourself on the surface of the avalanche, then the time of burial, so the duration of burial, is the key factor for survival. And in the 1990s, we published in Nature a first survival analysis, and we have seen that in the first 15 minutes, the survival chances are very, very high, above 90%. Survival probability under the avalanche. It is not a rescue probability. That means this is the chance of survival during the burial of avalanche. But after these 15 minutes, there is a steep drop in survival probability from 92 to 30% within 35 minutes. So this is the drama of the avalanche burial. And then you see there is a very flat course of the curve. That means that doesn't happen very much under avalanche if you're able to breathe. And this is the key for the long-term survival. So after the asphyxia phase, there is a latent phase and a little number of survivors who can survive very long. They can survive even 24 hours if they have a connection to the outside. I will bring an example for that. So these are the phases so far. And in the last year, we conducted a study and looking for the course of the survival and survival curve, and also the survival rates in the last 30 years, so 40 years. That means we have made a cohort study and included 1,643 critically buried persons in Switzerland. This is 23% of all buried, of all persons involved in avalanches, so 23 of the persons recorded are critically buried, and this number is quite high, so the results should be reliable. And what are the differences? In the old curve, we had 15 minutes of survival phase. In the new curve, so in the last decades, this survival phase changed and was cut to 10 minutes of survival higher than 90%. This means that the window of survival is very, very small. Then, same as previously recorded, the avalanche survival drops to 31% between 10 and 30 minutes. So there was no change. The second key difference belongs to the long-term survivors. Unfortunately, the long-term survivors increased altogether from 2.6 to 7.3%. So I don't know, maybe this is the result of all our efforts to improve on-site treatment of avalanches, avalanche victims and in-hospital treatment and the diagnostic procedures out of hospital. When we look at the course of the survival rate, this is not the survival probability, but this is the survived persons per 100 persons critically buried. Over time, we can see that in the 1980s, it was lower, then it jumped up, and it remained equal in the last 2 decades. That means in the 1990s, there was an increase of survival rate from 43 to 53 by 10%, and that's quite a good result. At the same time, the rescue duration, the rescue time and the burial duration changed. The rescue time was earlier in the last decades. Here you see the 4 decades for professional rescue and the 4 decades for the companion rescue, and both were shortened in time, in median time, especially in the first 2, between the first decades. In the last 2 decades, there was no change anymore. So we were not able to decrease the rescue time in the last 2 decades since the turn of the millennium. And what we have also calculated is the survival rates by rescue type, and the survival rates differ between the companion and the organized rescue services considerably. So by companions, we have a survival rate of 74 and organized 22. This means in terms of relative risk, the victims rescued by companions had almost 3-fold higher chances of survival. So what are the reasons for these changes in the last 4 decades? First of all, this change in the 1990s was followed exactly our first analysis of survival published in Nature, and this had implications for the construction of new search devices. The transceiver improved with 2 antennas, 3 antennas, and helped to reduce the rescue time. And there was conducted a better education of the skiers and ski tourers and the sport enthusiasts. So all these measures had an impact on the rescue time in the 1990s, but since the turn of the millennium, we were not able anymore to reduce these times. And why did the survival phase change from 15 to 10 minutes? So this is contradictory, because we do not know it exactly. Could be also trauma, a higher rate of fatal trauma in the first minutes of burial, but it could also be due to the climate change with higher snow densities nowadays. This could be a reason, but is hypothetically, because we have no data about the snow density at the site of the accident. There could be really an effect also of global warming. In the last 3 decades, we conducted a lot of field experiments. Of course, we have to do this because we cannot use only observational data. We have to do the experiments to look into the pathophysiology of a buried person. And if you want to dive into the pathophysiology, we published a review on the Journal of Physiology last year. But this is the setting we used since 30 years now. I used an artificial avalanche from a slope against a wooden wall, and in the wall we let the subjects breathe into artificial air pockets, and we measured the gases and in the air pocket and in the body of the subjects. Most of the subjects were mountain rescuers. And we have seen, even in 2003, that immediately after a few minutes, oxygen decreases and carbon dioxide increases. So we have an asphyxial state within a few minutes, 2, 3, 4 minutes, and only a few are able to complete the test duration because of the hypoxia and the hypercapnia. So the combination of hypoxia and hypercapnia occurs in every critical burial in an avalanche. And the hypoxia is also seen in the subject and in the air pocket. We have seen that hypoxia, the grade of hypoxia depends on the volume of the air pocket, volume 1, volume 2 liters. And we have also suspected that the snow density plays an important role. So we did other studies on the snow density, so targeted on snow density, and we have seen that the higher the density, the shorter the survival rate of the test. So the interruption of the test was earlier if the snow density was higher. That's obvious. That's also assumed. At very, very low snow densities, the carbon dioxide increases, however, enormously. And we have seen there is a threshold higher than 350 grams per deciliter. This is a high density in snow. It's difficult to survive. So it's difficult to breathe for a longer term. And all those tests have been interrupted prematurely. So long-term survival probably is a combination between hypoxia, hypercapnia, and if the duration of burial lasts longer than 60 minutes, also with hypothermia. This is called for the first time in 2003 the Triple H syndrome. But if breathing is possible, hypothermia may protect the brain from hypoxic damage, and a long-term survival in the avalanche is possible. And this shows also a little study in Ostrava with 179 victims, where you can see here that the survival rate, if there is a air pocket present, is as high as 67% compared to 4% if there is no air pocket present in all cases with a duration of burial longer than 15 minutes. So air pocket and airway and the patent airway, these are the conditions where you can survive under an avalanche. And the new devices, the new rescue devices, they go in this direction. There is a new device invented and developed by the Norwegian friends called SafeBag, and the SafeBag blows air from the snow into the area in front of mouth and nose. And we did a completely independent study on that, also in the field, and we have seen that there is an enormous difference. So this is the Kaplan-Meier curve. No, sorry, this is the cumulative risk of failure with the device and this oxygen support in front of mouth and nose, they could survive for a long term under the snow. This is exceptional. I would say we did not expect this. For us, it was a surprise. But it seems that these devices that are artificial air pocket devices, they could work. They could be an alternative or an additive to airbag and transceiver. So if the airbag helps you to keep yourself on the surface and you swim on the surface of the avalanche, and this device, the combination with this device could improve survival in the future. It's, of course, not proven. About the cooling rates. The cooling rate in an avalanche differs very much between 3 and 9 centigrades per hour. But Grissom found also a cooling rate in experiments lower than 1 grade. And in some few case reports, the cooling rates are exceptionally high, 9 to 14 centigrades per hour. So you cannot say how fast a person cools during the burial of an avalanche. If we put this together and look at the mortality causes of the causes of death, then in a retrospective analysis of autopsy reports, which are mainly done in Canada and the United States, not in Europe, we found that more than 80% are caused by asphyxia, 18% by trauma, and only a few cases from pure hypothermia. So the hypothermia as the only cause of death is very, very rare. Mostly hypothermia, you find it in combination with trauma or with asphyxia. And statistically, those patients who are found in cardiac arrest from an avalanche and resuscitated and rewarmed with extracorporeal rewarming, the survival rate is rather low compared to all causes hypothermia, which is higher, so 47 to 100% in literature, and from an avalanche the survival is only 12%, but it is not that low. So let's move on and go to the current guidelines. And there are a series of guidelines since the 1996 guidelines on the on-site treatment of asystole in an avalanche burial. And now we have 2 current guidelines published from ICAR. This is the International Commission of Alpine Rescue, the Medical Commission, and the ERC. And all those guidelines, they have the same questions. When to start with cardiopulmonary resuscitation, CPR, and which patient should be transported to extracorporeal rewarming. So the on-site triage and followed by in-hospital triage, these are the main questions and follows also the algorithms. So the algorithm for hypothermia, published in the New England Journal 2012, which was a basis for the treatment of hypothermia, does not apply to avalanche accidents. The ERC 2025 considers all those aspects of asphyxia, but I would show you the ICAR recommendations because they are intended for the rescue people on the site of the accident, and give you also the suggestions for the in-hospital treatment. And it consists of two algorithms. One algorithm is for BLS trained personnel, and the second algorithm is then for the ALS treatment out of hospital. The first sheet shows you how to go on if you have a first responder. The first responders should assess the airway patency, then estimate the duration of burial, and if the avalanche victim is conscious or has any sign of life, then you follow what is indicated in this green box. This means ECG and core temperature monitoring, gentle handling because of the afterdrop Thomas showed before, right before. Hypothermia treatment, consider hospital with ECLS if the core temperature is below 30 centigrades. Or you have a patient with cardiac instability and a systolic blood pressure below 90 millimeters mercury. If there is no sign of life, then it depends on the duration of burial, because the duration of burial, you need a certain duration of burial to have a hypothermic cardiac arrest. It's not in a few minutes like in a normothermic cardiac arrest. And therefore, we propose the 60 minutes as a threshold between the two treatments of asphyxia and hypothermia on the other side. So if there is no sign of life and burial duration is short, that means equal or less than 60 minutes, then start CPR with 5 rescue breaths. If you have a long burial, longer than 1 hour, then you should monitor ECG, start CPR, unless you have a long-term burial and the airway is completely blocked, so you have snow in mouth and nose, and the ECG shows asystole. Measure the esophageal temperature as soon as possible, and then move on to the second sheet, the algorithm for the ALS personnel, rescue personnel. And here, if there is a lethal injury or you have an esophageal temperature of more than 30 centigrades, you have not a hypothermic cardiac arrest. This is a normothermic cardiac arrest caused by asphyxia or trauma. And then, in this case, you continue with ALS for 10-20 minutes, depends on your regional protocol, and then you can consider to terminate CPR. So advanced life support at least 20 minutes if you have a short burial. If the burial is long, that means longer than 1 hour, or it is unknown, then you should go on with an ECG and CT monitoring, and if you see any kind of a cardiac activity, that means ventricular fibrillation or a PEA or a bradycardia, then do not give up hope and continue CPR as long as possible, so there is no limit of duration of CPR, and bring the patient to extracorporeal rewarming. If you have a ventricular fibrillation, a tentative of 3 shocks of defibrillation can be made, even more if you wish, but if it is not successful, again, the physician should not give up hope and continue with CPR and bring the patient to hospital for extracorporeal rewarming. What about asystole? We have heard before from Thomas that asystole is not a parameter for exclusion. And this works also in an avalanche. If there is a airway patent and a burial of longer than 60 minutes, and the airway is patent. If you have a systole, long duration, and no signs of life, and the airway is completely blocked, so there is no chance of survival, absolutely nothing. In hospital, you can use the HOPE score, and this is highly recommended. It has been described also already by Thomas, and we suggest to use it, but I completely agree that for avalanches, the parameters have a different meaning. So potassium, for instance, has a higher impact on the outcome compared to non-asphyxial hypothermia. And it is recommended to classify an avalanche victim which is critically buried, but it has a clear open airway and possibly an air pocket, to classify this patient as non-asphyxial. But this is a recommendation that we should look into this detail in the future a bit more when we have more data. So the HOPE score is on internet available, and if the threshold is 10%, if it exceeds 10%, then you should go on for ECMO. We have proposed also checklists. These are sheets, waterproof sheets with 2 pages, and these should be used to transfer the data authentically to the hospital, so that the decisive persons in the hospital have clear indications how to treat. Use mechanical chest compression, and so the clear messages are: if you have a cardiac arrest and burial less than 60 minutes, no hypothermic cardiac arrest is in front of you, and you can do ALS for 20 minutes. If the the burial is long and you have a cardiac arrest and the airway is free, go on with hypothermia treatment and transport to ACLS. But if there is an asystole on the ECG and you have a long burial and the airway is blocked, there is no chance of survival. So I have 1 minute, and I will run through the 3 clinical cases. So we had 3 years ago, Val-Chedus schedule avalanche. This was a short burial, 45 minutes, asystole, airway patent, and a very fast cooling to 24 degree, mechanical CPR, ECMO defibrillation at 29, and weaned after 30 hours, but declared dead after 66 hours. But the special detail in this case, that this victim became an organ donor. Lung, liver, kidney were transplanted, and this is very hopeful, I would say, also for the relatives. And this is not included in the recommendations. So in the future, we should consider also organ donation for avalanche victims, brain dead avalanche victims in short avalanche burials with cardiac arrest who come to hospital under CPR. This is the first message from this case. And a second case was the Setsas avalanche in January 23. This was a long burial, 23 hours was missed, found the day after the accident. And when the helicopter flew over Avalanche, the paramedic has seen that he had a hand out of the snow. He was found in, conscious, semi-conscious, with Glasgow Coma Scale 11, breathing, had a pulse, and the core temperature very, very low, 23 centigrades. But in this case, a very low cooling rate. But the specific point was not the status of hypothermia, and we from the beginning said, well, hypothermia is here not the main problem. The main problem is the hand, because to keep the hand out of snow during the night at low temperature, that means frostbite. And he had severe frostbite on all fingers, grades 3, grade 4. And we decided after rewarming as soon as possible to give him the complete frostbite treatment which is available and recommended. So first of all, alteplase, thrombolysis, and vasodilation with iloprost. So this was the main initiative to rescue his hand, and it was successful. So after a few months, he had no dysfunction, a full recovery of all fingers, except a mild hypersensitivity to cold and neuropathic pain. So the conclusion also, this is not included in the recommendations. So we do not know how to treat hypothermia combined with frostbite. This is completely new. It's rare, but it should be considered in the future. And the last one is a very nice case. 3 skiers were critically buried ascending a mountain at 2,400 meters. The burial duration extremely long, 4 hours. And patient 1 was dead at extrication. Patient 2 received forced air warming, no sequelae, because he was superficially buried under the surface of the, but the patient number 3 was interesting, and she was breathing. The rescue doctor, lady from Bruneck, from my hometown, had the impression the patient was breathing. But when she turned the patient from prone to supine, on the ECG she diagnosed asystole. Retrospectively, on the printout of the ECG, they have seen that it was not really a asystole, but it was a fine fibrillation. You see? And this can be misdiagnosed. So, assumed asystole, core temperature was also extremely low, 20.7. And if you have those parameters, so 4 hours critical burial, asystole, core temperature of 20, what would you think about that case? I guess many emergency physicians would not give any chance of survival, hopeless, but she was tough enough, the lady, Elisabeth Gruber, started mechanical chest compression, ECMO rewarming, and the patient completely survived with CPC1. So almost incredible. So in conclusion, no hypothermic avalanche victim with a patent airway should be declared dead until rewarmed and dead. And with the alternative rescue change to the hypothermia rescue change, in avalanche, the most successful part of the rescue is surge and extrication. BLS, ALS, and ECMO, they are running away our patients. So companion rescue is definitely key. Thank you very much.
Okay, so we have completely exhausted our time, so one single question if anybody has. If not,